Assalamu alaikum wa rahmatullahi wa barakatuh. And firstly, thank you for people for tuning in. Thank you to the Academia Library for inviting us to have this show. It's a medical show. I'm Salim Parker. I'm a general practitioner and a travel medicine doctor based in Elsies River. And I've been asked to host this show. And today it is my absolute pleasure and honor to be hosting Dr. Samina Parker. She's a dermatologist, a specialist dermatologist, and thank you for joining us today. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu wa rahmatullahi wa barakatuh. Jazakallah khair for having me on the show.
No, it's an absolute pleasure. And the reason we invited you was firstly, obviously you're an expert in your field, but secondly, we want to address an issue that is of a big importance to the community. I mean, it's been stated that in general practice, up to 10-15% of cases we see as doctors happens to be skin problems. And I thought we'll discuss one of the most important ones today, which is eczema. But before we get there, I mean, let's start with, we call the skin as well the biggest organ of the body. I mean, we normally think of the heart as the major organ, the brain, for example, is a big organ. But if you look at size-wise, the skin really is the largest organ of the body. How do you view the skin from a dermatological point of view and as a specialist as well?
So you said it very correctly that the skin is the largest organ of the human body. And, you know, at first glance it may just seem as a covering for the underlying tissue and bones, but it's actually a very complex structure because not only does it heal itself when it's injured or breached, it also has the ability to, you know, it's a large sensory organ, so it can perceive pain, it can perceive heat, cold, light touch, it can perceive pressure. And then of course, you know, the skin is divided into different layers and each layer plays a very important role. So we first have the epidermis, which is the outermost layer of the skin. And the epidermis is mainly made up of keratinocytes that are covered by a layer of keratin, and we call that the stratum corneum. And then we have the dermis, which is the middle layer, and that is primarily made up of a fibrillar structural protein called collagen. And then we have our subcutaneous fat or tissue, which we also call the panniculus, which is just underneath the dermis, and that of course consists of lipocytes that are separated by collagenous septae that have the neurovascular bundle in them. So each layer has, of course, a very important role to play. And also these different layers have different variations in different regions of the body. So the epidermis might be very thick on the acral areas, so the hands and the feet, but then it might be thin over the eyelid area, whereas the dermis is quite thick on the back and so forth.
Yeah, it's quite interesting that you mentioned the variations. I mean, we know, for example, the face has a lot of blood flow to it, the skin to the face, whilst other areas might be slightly different. And there's also different sensitivities that the skin has to different precipitants and to different what we call stimuli. And we're in the middle of winter now. It is cold. I just came back from Saudi Arabia, alhamdulillah, after Hajj, where the temperature was going at 45 degrees, and what we saw were blisters on the feet. But we came back to my practice, and kids, even adults, were complaining more and more of skin irritations, eczema flare-ups and so forth. So it's winter in Cape Town and South Africa, obviously. Why is there this flare-up in winter, especially in Cape Town? I don't know whether it's the same in the rest of the country, but Cape Town in winter, we see flare-ups of itchy skins, kids scratching themselves open, adults also complaining more and more that there's a problem in winter time especially. So why is that the case?
So in winter, of course, these comes along changes in humidity in the environment and also changes in the temperature. And of course, this is the perfect environment for skin to be very dry, and that's what we call xerosis. Okay, and then of course The use of indoor heating, which we make a lot of use of during winter, can also cause the skin to become dehydrated and lose a lot of moisture, and it causes the surroundings to be less humid, and that of course causes irritation and dryness. And then in winter we of course wear a lot of layers of clothing, and a very well-known irritant to skin, especially in eczema, is the fabric called wool. That can irritate the skin. And then
irrespective of whether it's pure wool like merino wool or not, wool itself on its own.
Irrespective, yes, wool itself. And then we also tend to take hot baths or showers in winter. And they say that in winter it's better to take, generally it's better to take lukewarm baths, because obviously a hot bath alters the pH of the skin. And in the skin we have pH-dependent enzymes that are responsible for producing the natural moisturizing factors, such as the ceramides, that play a very important role in the epidermal barrier function. So you don't want to, alter the pH of the skin.
So are you suggesting that on the ice cold winter day when the shower is just perfect, you want to make it, that's just the reality, that's what people do. We know, for example, in the gyms, people normally spend maybe 5 minutes having a shower. In winter, 15 minutes, we've observed this, and it's hot water. So that's not good for you.
Not good.
Okay.
So you should rather have a maximum of 10 minutes and in lukewarm water.
Even though that might be uncomfortable for you in winter.
Yeah.
It's going to be difficult.
If we weigh up the pros and cons.
It's obviously for people who are suffering from eczema. Yeah, okay. Now, we're talking of eczema. So what exactly is eczema? Everyone seems to have different definitions of it, but what exactly, medically speaking, dermatologically speaking, is eczema?
Okay. So eczema is just an umbrella term for an inflammatory condition which affects the skin, and we get various types of eczema. And the most common type is atopic eczema or dermatitis, and dermatitis is just the scientific term for eczema. And what it is inflammation in the skin. Fortunately, it's not an infection. It's not something contagious that can be passed on from individual to individual.
But it tends to run in families.
So atopic dermatitis definitely has a strong familial predisposition, and that is the strongest risk factor. That is a family history of atopy. And by atopy, we mean a genetic predisposition to having eczema, asthma, allergic rhinitis, or hay fever. And they say that 70% of patients with atopic dermatitis have some family history of atopy. So either parents or grandparents or siblings that have asthma, eczema, or hay fever. And they say the risk increases, of course, if there's one parent that has atopic dermatitis or atopy, then your risk is 2 to 3-fold. If both parents have it, then it's 3 to 5-fold higher.
In fact, my kids always blame me when they start scratching. This is daddy's fault. So we know the genetic predisposition is there. But are there other risk factors? We talked about the genetic ones. Are there others? We know certain food types can aggravate it. Do you want to expand on that a bit?
Gee. So fortunately, eczema is not caused by food. Okay, that's the good news. So you are allowed to obviously follow a healthy diet. That's what we always advocate for. But sometimes what happens is, in the patients that have very severe atopic dermatitis, you can have food being a trigger. Okay.
Right.
And for example, so it can be peanuts, it can be milk, it can be, various things. And we always tell patients that they need to watch out for a specific identifiable trigger. So there's nothing that one can pinpoint and say, this food causes eczema. But it's generally foods that you watch out for, you keep an eye out for, that can cause a trigger or a flare-up that we usually advise that they rather stay away from.
So if people have long-term eczema, you would ask them to keep a diary to note down what they ate, what they were inhaling, or what they were touching at certain times?
So it's a very, very small percentage of people that have proven food allergies in patients with severe atopic dermatitis.
And inhalants or any other precipitants?
Even inhalants. So the older you get, the risk increases for allergy to inhalants, but it's still very, very small.
So what are the precipitants that are known? What would you ask someone before you treat them? generally speaking, as a universal avoidant, what should they try to avoid? What should they try not to get into contact with in those who have severe eczema?
Okay, so occupational history is very important, because if they work, let's say, in a furniture manufacturing factory, okay, and then of course you are exposed to dust. Pollen is a well-known trigger. If you have cats and dogs at home, so their dander, cat hair, dog hair, we usually ask about, and then of course certain detergents. And then in terms of food, it would be peanuts, milk. Okay.
But they will know that they have this allergy.
Yes.
And carpets, often people are advised to take carpets out of the house. Now we're talking about children, for example. Yeah. So if say, for example, you have a 2-year-old with severe eczema, what food and what other precautions would you advise the parent to be aware of?
Sure. So generally, we don't tell parents to, restrict their food unless there's a specific identifiable trigger. Okay. So for example, if mom says, doctor, every time I give him nuts, he definitely breaks out into a rash. He's definitely more restless, he's itching, his skin, breaks out into wheals, then we tell them rather avoid the peanuts. But there's nothing specific that we pinpoint, and say that this is the cause for the eczema.
For eczema. Okay, we're not talking about urticaria or allergies, we're talking specifically eczema now.
Eczema,
okay.
Yes.
No, that's fine. Just, we're talking about severe eczema, but is it easy to actually classify it? I mean, I'll give you an example. One survey that I came across showed that 40% of the patients thought that the eczema was severe, but the doctors felt only about 80% of them had severe eczema. A mother who can't sleep for 3 consecutive nights because the child is itching and restless will tell you, my child's got severe eczema. A young girl who's got a eczematous face, rash on her face, is going to tell you, this is bad. I mean, it might be 1 centimeter small, for it's going to be a pumpkin. I think we have to be aware of that. So is there a scientific way of classifying as to the severity of eczema?
Sure. So we can use clinical signs. So after you've taken a good history and you examine your patient physically, we definitely look for clinical signs of severe eczema, and one of them would be if they have any blisters, okay, in the areas where the eczema is, and then if there's any weeping, any crust, and then erythema and swelling. That's generally a sign of acute eczema.
Erythema is redness.
Yes, erythema is redness.
But does it also depend on the area? I mean, if it's what you've described for 5 centimeters, would that be severe? Or?
No. Okay. So we use certain criteria. So the first is obviously clinical signs, as I said. So that's a sign of acute eczema. Then we look for signs of subacute or chronic eczema. And subacute would be erythema, so redness, scale, which is peeling, and then swelling, and then chronic eczema, which is obviously which has been there for a long period, would be like canification. So when the skin becomes very thick or leathery in the flexural areas, and that's obviously represented with hypertrophy. So the skin becomes thickened, it becomes darker, and there's also increased linear markings in that area.
When you say flexural areas, what exactly do you mean by that?
So it's usually your cubital fossa, okay, and then it's your popliteal fossa.
Behind the knees.
So in front of the elbows, behind the knees. That's the typical distribution in an adult patient, but obviously in kids it's different. So in kids it likes to affect the face and the extensor surfaces. So it's the back of the arms and the front of the legs.
Okay.
And the other more objective, but obviously nothing is 100% accurate. The other more objective criteria that we can use is called the SCORAD, where we look at obviously clinical signs. So we look at the severity. So in terms of erythema, in terms of scale, swelling, excoriations, and then we also look at the surface area of the body that's affected, and we use the rule of 9. Okay, so we measure the area that's affected, plus we look at the objective signs of redness, swelling, excoriations, and then we also ask the patient to grade their pruritus.
Pruritus, itching.
Itching,
Yeah,
yes.
right.
And, you know, looking at how it's affecting their quality of life or how much sleep disturbance is causing. So that's the one. And then the other one that we use is called the EASY criteria, which is the eczema area and severity index, which also looks at the area affected and then the severity of the lesions itself.
Right. Well, that's for specialists,
Those are
not
more
for us
scientific.
GPs. Okay. But generally speaking, you know, we're looking at what the patient describes. I'm talking from a GP perspective,
Yes.
and also how the parent and the siblings, or
Sure.
at times the spouse describes it. I mean, the person is scratching all night long. So those are the criteria we often use, but
Sure.
it's very, very subjective,
Subjective, of
unfortunately, from our point of view. So we've got a good idea as to what exactly eczema is, atopic one. How do we treat it? And I know, and let's start with the milder form.
Sure.
And then we can progress up to the more the moderate form and then the more severe one. So let's start with
Sure.
the mild one. How
So
we
there are
treat
a
it.
few pillars of treatment, and the first and foremost pillar of treatment is, of course, education and counseling. So if you don't counsel your patient adequately, you've already lost the battle because you have to teach them about the diagnosis. You have to teach them what the problem is with eczema so that, you know, when they go home with their treatment that you've given them, they know exactly what they're using it for and how it's going to make a difference or improve their skin. So that's education and counseling. And then the next thing we advise is, of course, so the main problem with eczema is that there's epidermal barrier disruption or dysfunction. So you want to try and maintain that epidermal barrier as best as possible.
That's the outer skin,
Yes.
the outer layer of the skin.
Yes,
right?
outermost layer of skin, and you can, you know, compare it to the boundary walls of your home. I always use that example. So you want to make sure that the boundary wall is intact, the bricks, the cement, everything is intact. And the best way to do that is, firstly, so you don't want to use any harsh cleansers or soaps. You know, conventional soaps that we get over the counter are far too harsh for the skin. So we usually...
What do you mean by harsh? Do they contain chemicals that disrupts the barrier, or
Yes, yes. So soaps have something called sodium lauryl sulfate, which is used as a preservative. And that definitely is a well-known culprit and irritant to the skin. Even aqueous cream has it, which is why we advise that patients use aqueous cream as a soap substitute as opposed to a moisturizer.
And what if they have irritation due to it?
So that's why, so they apply it, they keep it on for very little, so they use it like a soap. So it's only in contact with the skin for a very short period, and then they rinse it off in the shower. If you want a better alternative to aqueous cream, then emulsifying ointment is pretty good.
Okay, so let's go back to aqueous cream, because it's often used as a moisturizer.
Yes.
So you're saying it should not be used as a moisturizer.
No.
It's a soap substitute.
It's a soap
It should be
substitute.
washed off.
Yes, that's correct.
And so that's cleansing the skin. Moisturizing,
So
what would you suggest?
moisturizing, we normally recommend Ceto Macrogol, okay, or anything that is not fragranced, okay, so preferably nothing that has fragrance in it or colorants in it, or, you know, nothing with too many chemicals in it. Ceto Macrogol is the best. And then we tell patients the best time to apply it is, of course, after a shower, because when the skin is moist, it's like a sponge, it just absorbs everything. And then they apply it throughout the day liberally, as often as possible.
So there's no limit. If they feel that it's feeling dry, they can put it on.
Yes.
And there's no long-term side effects to Cetamacro.
No.
Are there any other ones? I mean, unfortunately, it's got a slightly off-putting smell. Some people don't like the smell of it.
Yes.
So, and I think that's why there's fragrances put in it.
Sure.
You advise that not to be done. Are there any other moisturizers?
Emulsifying ointment can also be used as a moisturizer.
Any other commercially available ones that might be more acceptable for example, young teenagers, because you can smell Cetamacro from a distance away.
Sure. So I normally advise that they use Epimax, E45, Epiderm. These are all available over the counter.
All right.
So if you walk into any Clicks or Dis-Chem, they're definitely on the shelves.
They're a bit more expensive, but they're more tolerable. But is there a time limit that, because they tend to be cream-like and they tend to evaporate, for lack of a better word, more easier. So do you have to put the more commercial ones, do you have to apply it more frequently?
So if your skin, as a rule, if your skin is dry and scaly, then we like to use something that is lipid based. So
Right.
that is an ointment. Okay? If the skin is not dry, and let's say it's more towards the spectrum of acute eczema, where it's a bit weepy, then we prefer to use creams.
Okay. So,
Okay,
right.
so because then it evaporates quickly, it doesn't occlude the skin like the lipid or the greasy one does.
Right. So the lipid-based one is basically to moisturize, and
Yes.
the
More
cream,
for dry skin.
Yeah, and the cream-based one is when there's actually some form of inflammatory activity.
Yes, absolutely.
Okay. So now we've applied this, the skin is getting worse. So now we're sitting with a bit of, it's childish or adult or teenagers scratching. They're waking up at night, they're scratching.
Yeah.
So there's clear inflammation.
Yes.
Not too bad. Maybe, like you've mentioned, the flexural areas in the elbows and behind the knees. How would you treat that?
Sure. So now we move on to the fourth pillar of treatment, and that is a topical corticosteroid. And then depending on the site that you're treating, for example, face versus the rest of the body is of course different.
Right.
And the severity of the eczema, we can either go very potent or we can go mild. Okay, and then we use topical corticosteroids. So for example, if you have acute eczema and it's looking very bad, then we rather heat it with a high potency steroid, and that is Dovate ointment.
Right.
Okay, whereas if it's just a mild form of eczema, then we'll rather treat it with something, less potent. So we can go with either a medium potency steroid, so something like Cortoderm or Lenovate, or we can go with a very mild one such as 1% hydrocort or Mylocord.
The two things that you mentioned. The one is when it's on the face or the rest of the body.
Sure.
Why is the distinction made between the face and the
Sure.
rest of the body?
Because the skin is a lot more sensitive. Of course, it's a cosmetically sensitive area, and plus it's quite thin compared to the rest of the body. That's why we don't use Dovate on the face, for example, because that's very high potency. And the strongest that we can use on the face and the sensitive areas like the genitalia, the skin folds, is Advantan.
Right. Now, one other question is that often people find that they use for example, the potent one like Dovate on the skin, and for how long should they apply it? Because we often find that people find that they just want to continue applying it. They don't want the rash to come back.
Sure.
So, and even on the face, they've used, for example, the milder potency steroids on the face, but it worked.
Sure.
A couple of days later, it starts coming back.
Okay.
So for how long should they treat it? And to prevent using steroids again, what should they do immediately after the treatment period?
Sure. So the rule is hit it hard and hit it fast.
Okay.
So we start
And short,
high.
I presume.
Yes,
Okay.
yes. So we start high. As soon as you see a clinical response, so as soon as the patient starts feeling better, the aim is always to wean them off the steroid. So you don't want to go from Dovate to zero. You want
Right.
to gradually taper down the steroid, okay? And of course you use the very high potency one for a very short period. So I usually tell patients that you use it for 3 to 5 days until the skin settles down. Then we go from a high potency one to a medium potency one for a few days.
What do you mean by settle down?
So if you see that your skin is less red,
Right.
less scaling, the itching has become significantly less, that's a sign of a good clinical response.
So you can sleep at night without scratching, for example.
Yes, yes.
It's often difficult to quantify it. I mean, often we say when you're feeling better.
Yes.
What does feeling better mean? For me, it could be being able to run 1 kilometer. For a colleague of mine, it'll mean he's able to run 15 kilometers.
Yeah.
Then he's better. That's why I'm asking specific questions. So it's
Indeed.
actually nice for the patient then to realize what to do. So it's
Yes.
3 to 5 days with a high
Yes.
potency steroid,
Yes.
depending on the site. Obviously,
Yes.
high potency on this, for example, on the leg, less potent on the face. So
On the
3 to
face.
5 days of that. After that, you
And
scale
then you
down.
start scaling down or weaning them off, and then you go medium strength, and then you go low potency, and then you stop with the topical corticosteroids, and then
Wait, so 3 to 5 days with a high potency one, 3 to 5 days for the medium.
depends on how the patient
Okay,
responds as well.
right.
Okay, but usually with medium we can go a bit longer, so it can be a few weeks.
Okay.
Or even a few months, and then the mild one we usually tell patients just until the rash disappears. Okay.
Right, so now the rash is gone, patient is itching.
Okay.
Would you use any anti-itching tablets?
Yes. So I'm
Which
going to
ones?
get to that
Okay.
now. So after the topical corticosteroid, so you asked a very important question about side effects. So usually what I advise patients is not to use it every single day and not too frequently. So once a day of the topical corticosteroid is as effective as twice a day. There are actually studies that have shown that. So once a day, and then I normally tell them only for 5 days a week, so usually a Monday to a Friday. And this prevents something called tachyphylaxis, and that's when the skin becomes very used to it and you need more and more of the steroid or something, you know, higher in potency to achieve the same results. So you rather want to give the skin a 2-day break from the steroid. So you use it from Monday to Friday to prevent tachyphylaxis and also to minimize the side effects. Okay? And then we move on to our medium potency one, and as the skin improves, we move on to our mild corticosteroid, and once the rash disappears, we put them on maintenance treatment, and that's where your topical calcineurin inhibitors come in. So things like tacrolimus or pimecrolimus.
Right.
That's where we use it, and we usually advise patients to use it in the affected areas where the eczema usually comes out. But you can use it for, let's say, once or twice a week. So I usually tell them weekend therapy is perfect. So on a Saturday and a Sunday, even if there's no rash there, remember the eczema hasn't been cured, it hasn't gone away completely.
Right.
You want to keep the flare-ups away, so you apply it in the affected areas twice a week.
It's easy to prescribe it. It's difficult to buy it because it's expensive. So, we've got to balance it between applying it, like you said, weekends, which most people should be able to afford, and keeping the eczema completely at bay by using moisturizers. Sure. If it's a problem of cost and the person can't afford Elidor, for example, what would you advise them after the steroids has been stopped? Sure. Would you just advise moisturizers or?
They certainly have to continue with the soap substitute and the moisturizers daily, liberally as often as possible. And then every now and then, if they do notice, that the eczema is starting to return, then you keep your mild corticosteroid handy and you can apply it just to the affected areas if needed.
Right. We've talked of high potency steroids. We kept harping on the fact that we should not use it for too long.
Yes.
And you mentioned already tachyphylaxis.
Yes.
What are the other potent side effects of steroids, and why are we so cautious about people not using it for prolonged periods?
Sure. So the other side effects of topical corticosteroids are, of course, it causes skin atrophy or thinning. It can cause stretch marks or striae. And then it also, remember, it's an immunosuppressant, so it causes local immunosuppression in the area where you're using it. And by that I mean, if you're going to use a steroid for a longer period in a certain area, then it makes you vulnerable to other opportunistic infections in that area, especially fungal.
Right.
Okay.
And when you mention all these side effects, are they reversible or are they permanent?
So the striae, unfortunately, you have to stop the corticosteroids immediately. That's not reversible. Even the skin atrophy, we stop the steroids completely. Some of them are not reversible, but of course, if they pick up a superimposed infection, that is treatable.
Right. Yeah. So because we've often seen patients with, you can see the blood vessels in this on the face, for example.
Telangiectasia. Yeah. Yes.
Right. So those type of things are not reversible.
Unfortunately not. They're treatable, but not reversible.
Okay, so the point we have to take home point here is steroids, use it correctly, but do not overuse it because it's got major side effects associated with them.
Yes.
Okay.
Definitely under the guidance of your general practitioner or your dermatologist.
Right.
I don't want people having steroid phobia and not using steroids when they actually need to. That's why I'm just emphasizing that they do it under the supervision of their doctor. Right. And of course, it takes a little while for the side effects to, manifest. So it can take, let's say, at least 6 weeks of regular use of a steroid for you to actually start seeing the side effects that I've mentioned now. So not to be afraid to use steroids when you actually need to, but just need to be used correctly.
Right. So for a couple of weeks, under doctor's advice, should not be a problem. generally speaking.
Gee, that's
Okay,
correct.
no, excellent. So we've treated the skin part of it, but let's look at some of the symptoms. Itching.
Sure.
What do we use for that?
So we normally prescribe antihistamines,
Right.
and we usually use sedating antihistamines, which are given to patients before bedtime at night, so after
Right.
supper. And that doesn't necessarily take the pruritus or the itch away, but it definitely helps them sleep better so that they don't wake up at night scratching.
Right. Is there anything specific that you can advise for the pruritus itself, the itching part?
So unfortunately, not that many options, but it's more to help them sleep.
Right.
Yeah.
Because if they sleep, they tend not to be aware of the pruritus and not scratching.
Exactly.
Kids, however, you still will find still scratching away, even if they're fast asleep. And I think parents pick that up. And this is where we often battle. You don't want to sedate the child too much, but you also want to treat the patient, but
Don't want
also
them
the
to
extended.
suffer, of
You need
course.
to treat the extended family, like the mother, like the partner as well. So it's often a difficult issue. Now, when it comes to antihistamines, we know that there are sedatives that are addictive. Antihistamines, do they have long-term side effects? Do they have addictive properties? Or unlike, I'm not talking about tranquilizers now, which we know which people often use to sleep as well. But do the antihistamines have any long-term side effects?
So they can cause drowsiness, of course, which is why we don't give the sedative ones during the day, especially for working individuals or individuals that are driving or on the road. It's dangerous. And then, yes, they can definitely be addictive.
The sedating ones?
We also don't like to prescribe them chronically.
Right.
Okay.
And the newer antihistamines, such as the cetirizines, do they work for eczema?
More for urticaria.
Okay.
Okay. But if you have a patient that's got, other atopy or atopic features, so if they have allergic rhinitis, if they have asthma, it definitely plays a good role.
Now, we often call this the triad of eczema, of asthma, and hay fever. Is there any magic bullet that you can think of, that you can say, hey, this will treat all three, as far as you know? Except long-term steroids, which you don't want to use.
Unfortunately not. I wish there was.
And this is what we often struggle with as GPs, for example. You need to treat the asthma. It's not responsive. In fact, they often use oral steroids, which of course we know is going to help the eczema as well. So when we've talked of topical steroids, oral steroids, is there a place for that?
Yes. So usually when the eczema is acute and extensive, so if the patient is covered in blisters, they have weeping eczema, they have crust, and it's a large body surface area that's affected, then we give them a course of oral prednisone, but also for a very short period. So let's say about 5 days, and that's because it definitely improves the eczema, but then patients, it gives them the false hope that, this is a cure for my eczema.
Right.
They see the dramatic clinical response, and then they think that prednisone is the go-to medication, which we don't necessarily encourage, because
Why
we know
not?
all the side effects of prednisone. Weight gain, hypertension, diabetes, adrenal insufficiency. It can cause acute pancreatitis. I mean, there is a shopping list of problems.
Absolutely, and this is, we often have to try to convince patients that it's not the magic bullet, like I've just previously mentioned, because of these major side effects. And unfortunately, these side effects don't manifest early.
Yes.
The results of it, like excellent skin improvement, manifest within a couple of days.
Yes.
But this long-term, and people often feel, this is what we must use, let's continue using it. It doesn't work like that. And that's why, like you mentioned earlier on, education is important. Now, we often find people scratching away and you get super-added bacterial infection on there. How common is that, and how do we approach that?
So it's very common, especially amongst kids. That's why we always advise parents to keep the children's nails short and also moisturize as often as you can, because, dry skin is the most common cause of pruritus.
Right.
So if it's kept nice and moist, the likelihood of it itching will be less. And then the most common superimposed infections that we see are staphylococcal infections. So Staphylococcus aureus is an organism that's part of our normal flora of our skin, and it's an organism that's found, abundantly on our skin, in our nasopharynx, the perianal area. And what often happens is kids, they scratch, or they do a bit of nose picking or scratching.
No, they've got to try it, so they do this, and then
and
they
then
start
they
scratching
scratch,
as well. Yeah,
exactly.
Yeah.
And as soon as the skin is breached by the scratching, or opened or exposed, the organism, of course, enters the skin and takes advantage and causes the secondary bacterial infection. The other infections that we often see are herpes simplex virus, and we also get a condition called eczema herpeticum, which is actually a dermatological emergency. So yes, it's definitely very common,
and
especially the
treatment-wise,
bacterial infections, and then of course fungal infections as well.
And the treatment of the bacterial ones?
So we usually give a course of antibiotics, and it's a broad spectrum, so something like coamoxiclav or cefalexin. I personally like cefalexin, especially in kids, because it has both cover for Staphylococcus aureus and Streptococcus, and it doesn't give you the diarrhea that Augmentin normally gives.
Right. Yeah.
And then we advise parents to use an antibacterial wash to cleanse the areas,
Such
the
as?
affected areas. So betadine wash. Unfortunately, it's been out of stock in our country at the moment, but you can always use bleach baths at home, and they help with the staph colonization on our skin, so they help eradicate the staph.
What do you mean by bleach baths?
So I know it sounds very strange, but it has been proven that bleach baths definitely help with decolonizing the staph on your skin.
How exactly do you do that?
Sure. Okay. So you fill an adult-sized bathtub halfway with lukewarm water, and then you add a 1/4 cup of jik, plain jik, non-fragrance jik, that's bleach, in the water, and the patient or the child lays in there from the neck down for about 10 to 15 minutes.
Right.
And this is done thrice a week, ideally, but I mean, if your schedule is quite busy, it's understandable. You can do it once or twice a week, but ideally thrice a week. And that actually decolonizes the staph on your skin, the bacteria.
Okay. And this is for people who frequently get
bacterial infections. Absolutely. Yeah. And then we also give an antibacterial ointment called Nuban or Bactroban, which they can apply on the affected areas, and also with a cotton bud on the inside of both nostrils, because that's where the organisms are abundant, as a staph eradication measure.
I think we're getting to the end of our time today, but you mentioned fungal infections. How often does it get, do you get fungal infections on top of the eczema?
Yes, so especially in patients who have been using the topical corticosteroids for a long time, and we know that corticosteroids do cause local immunosuppression, so it allows the fungi to grow in that area. And we call it tinea incognito, so it's a fungal infection in disguise.
Yep. Okay.
And the way to tell the difference is, so usually with eczema, your plaques are ill-defined, and they tend to have this scale that is it's a different type of scale. Whereas with your tinea infections or your fungal infections, ringworm is the common name for it, or layman's term. You have a very well-defined plaque. It's a red erythematous plaque with fine scale at the edges, and we call it an active border or a raised border.
So you can actually see where it's encircled.
Forms a little ring, okay? And then with central clearance. So the area in the center of the plaque is unaffected.
And how do you treat that?
So we usually treat it with a topical antifungal. Of course, you stop the steroid first, so no steroids in that area, otherwise the fungus is going to thrive. And then we use a topical antifungal agent twice a day. If that doesn't work, then we turn to systemic antifungal agents. That's your oral antifungal medication.
I think we need to end off, but the very last question is, those very severe patients that I've gone through the mill now, even given them oral steroids, now I'm referring them to you because I don't know what more to do. They're not responding to that. What are the last and the novel treatments that exist nowadays for very severe eczema not responding to steroids and to the tacrolimus like you mentioned now.
Sure, sure. So of course with any skin condition there is a treatment ladder that we use.
Right.
And as you said, nothing has worked so far. Then the next step would be UV therapy. So we usually give them, we apply photosensitizing agents to the skin, or we give them oral photosensitizing agents, and then we shine UV rays on them that help suppress the inflammation in the skin. And then the other treatment modalities would be immunosuppressive agents, so something like methotrexate, azathioprine, cyclosporin. These are common medications that we use, but of course they come with their own, side effects and side effect profiles.
So they should be under the auspices of a dermatologist.
Yes, preferably.
Right? But they come with severe side effects. I know people can't be exposed to anyone with TB. We know that they can pick up bacterial infections. So these must be after thorough investigations and under the auspices, again, of a dermatologist.
Definitely, and the last resort, after you've tried everything else, and then that is usually what we turn to.
And do virtually everyone respond to that, or are there failures to that as well?
There are failures to that as well, but the majority of patients show a very good response.
That's excellent. I think we've reached the end of our allocated time. If you're okay with it, we've barely covered atopic eczema only. There's about 6 or 7 different types of eczema that we haven't even touched on. So, inshallah, it will be the subject of the next program, and hopefully the next. We'll see how the series goes. But again, thank you so much, Dr. Samina Parker. She's a specialist dermatologist. I don't know whether you put your practice details. I'm sure you could put it on the screen. You're based in Pinelands?
Yes, that's correct.
At one place, but that's one of many.
At the Dermatology and Hair Institute in Pinelands. Okay,
it's a long word. I think we'll have to just put it on as a slide, because she can be contacted there. She's in private practice there for a few months now already, and she's going to be there for a while, inshallah. But again, thank you so much. Shukran for coming here, enlightening us. I learned quite a lot, and I'm pretty certain parents, those who are suffering from eczema, and also those who are in contact with others will have been enlightened by this. So the stepwise approach is moisturizers. If that doesn't work, see a doctor for steroids, topical steroids. If that doesn't work, go to the dermatologist and see what they can offer you. And inshallah, they will sort it out for you.
Yes,
Shukran so much for your time.
I learned a lot. For having me.
And again, inshallah, we'll see you again on this program.
Ameen.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.